everyone, and welcome to the Totally Adequate podcast. I'm April Beane, and we strive to convene conversations around the complexities of provider network management, including the latest news, trends, innovations, and policies. Our goal is to improve access to healthcare across the nation, and we hope to bring you, our listeners, moments of innovation that will help you craft the future of care. Today, we have part 2 of a 2-part series with Steve Levin, the CEO of Quest Analytics. We're going to be talking about structuring networks, or as our guest likes to call it, the craft of the art of the impossible. It's finding that right size between broad networks and narrow networks, aligning your network strategy with your operational goals so that you have improved outcomes and improved access to care. Joining Steve is Jim Brown, Vice President of WPA Markets, Operations, and Strategy at Highmark Health. All right, Steve, welcome back to the Totally Adequate podcast. Thanks for joining us.
Thank you, April. Jim, good to see you. How have you been?
I'm doing great, Steve. Great to catch up and talk with you again.
You don't sound so excited.
It's Friday afternoon. It's been a bit of a week, but I'm excited and raring to go.
All right. So you and I have had running conversation with this for a while. Broad networks, narrow networks, everybody has a title to it. In your Highmark spot, like, what are you guys like in the world of broad, narrow? What's your emerging sort of thoughts on this whole kind of conversation?
Yeah, Steve, hot topic, a topic that's been hot for probably 10 plus years at this point. Yeah. I would say the nomenclature is becoming increasingly important. Broad and narrow have connotations associated with them that I don't think anyone appreciates within the industry, outside of the industry, particularly if you're a member or a consumer. It doesn't make sense. So we've tried to begin to move away from that, but it's a really accepted kind of terminology to at least understand what you're talking about when you start to think about how your network is constructed or what the possible construction of your network might be. Here in Western Pennsylvania and across the Highmark delivery footprint, we're constantly kind of in a state of evaluating now what our network looks like and how we think it could potentially be improved over time. It is an exercise of courage, strength, perseverance. It's not something that happens necessarily overnight. And we've begun to think of constructs that take into account not just a broad versus narrow perspective, but much more focused on outcomes and quality and cost, and the concept of almost a network within a network, where you can have access to providers in case a big bad thing happens. But on the common everyday things, we can help you get to the provider who's going to treat you with the best outcomes at the lowest cost with the lowest disruption to your daily life.
Let me, that was a long story arc. Yeah. Let me see if I can go back to sort of the beginning of it. So broad, narrow, it's really interesting. Like, I've always had this view that these words have always been sort of an internal shorthand.
Yeah.
Right? You never want to tell a member that congratulations, you joined the narrow network. That was like that's not a good message.
Yep.
So they, in some ways, they represented an economic proposition that the insurance plan was thinking, right? Like narrow, control cost, control access, control throughput. So you trade up accessibility, sort of time, convenience for value, effectively.
Yeah, I think that's exactly the right way to think of it, Steve. And value can be defined in a number of different ways. We're constantly looking at value as what the consumer sees as value. So oftentimes the consumer might not see the cost savings as value because that might be at the employer group level, might be at the insurance company level. So we're looking more at experience, outcomes, and speed to service. When a consumer tries to use their insurance or their benefit plan or their network, are they able to use it in a manner where they don't have to pick up the phone and call somebody to say, this isn't working the way I want it to work?
Right. So so let's talk about that broad thing, because one of the things that I've been spending a lot of time thinking about is like, how broad is too broad? What are measures of excessive breadth, et cetera? I've had a lot of people kind of explain, we never remove anybody from our network. sales doesn't want anybody taken out. But there's a huge number of costs to that. Like these networks that have, everybody in them is sort of like, it's not a free thing. It's like, it has real costs. I think, and I know you've had some experience with that.
Yeah, I think, Steve, let's call a spade, right? Like the insurance industry, and not just Highmark, others, our provider data management techniques and skills and tools are archaic at best, and it is not inexpensive to maintain a single provider. And when you multiply that over 20 plus years of having a network that's been in place, that has been really just added to as doctors move into the geography or new providers enter into the market without sort of a lot of active management of that network, you're now talking, numbers that are kind of astronomical in terms of number of folks in a network, number of folks that might be in multiple specialties at this point because they have board certifications in a number of different, service types. Right. And then, multiple different geographies where they're theoretically able to serve a patient or member. I'll use the Western Pennsylvania example. Highmark owns a health system in Western Pennsylvania. That health system employs 2,000 physicians. Those 2,000 physicians, though, have multiple locations each. And because of the way that practice of medicine is delivered nowadays, our cardiologists, as an example, we list them as potentially treating patients at many different office locations just in case. And so then from an insurance company perspective, we have to represent that each of those providers is available at those different office locations. And so it becomes an exponential math problem, which then gets into our systems and costs an incredible amount of money to maintain long-term.
Yeah, it's very interesting. I just this morning was looking at some new data analytics by stitching together a bunch of different sort of kind of primary content, price content, activity content, et cetera. The same doctor can have sort of activity at multiple different networks. Like the same cardiologist or orthopedist, you can find them effectively having activity in 3 or 4 different hospitals or ASCs, et cetera. And lo and behold, what you discover is that like the same doc can in fact have 4 different addresses and 4 different, price and quality views. Like it's not one-to-one. It's not a simple, conversation.
And I think that makes the practice of managing your network harder than you might anticipate, just from like the outside looking in, or someone a little bit naive to the workings of the industry saying, "Oh, broad versus narrow." Isn't it as easy as just saying, "Here are the top, 50% of my performing providers. That's the network you should have. It's done. Move on." And what's the problem with this? Why is it?
Right. You and I would have very short careers.
That's exactly right. Well, I'd be off doing something more glamorous than appearing on a podcast with you, Steve. But yes, that's exactly right. And so I think the complexity of care delivery in the United States is hard fundamentally to understand as a consumer, and it's our job in this industry to try and make it easier. But that just means you have to understand the construct of a provider network. And the value of that provider network at a level that you might not have anticipated you have to get to.
One of our earlier conversations, I just want to see if I can remember this properly. You communicated or shared this sort of, there was that the network was at the root of a whole bunch of sort of your inbound customer service, lack of word, feedback, to use a polite word.
Yeah.
Do I remember that right?
You did, Stephen. So we're sort of evolving the way we think about provider network as being holistic to a product strategy.
Right.
We're trying to move to a mentality that we're selling a product to our members and consumers, not necessarily an insurance plan. When we think about a product, that includes benefit plan, it includes provider network, it includes customer service, it includes member call-ups. Of all of those areas, the root cause of most of our member complaints or member grievances or people calling into the health plan for issues is provider network inaccuracies. So a member tries to access a service, tries to use their insurance benefit, They use the directory that's been provided to them. It's a directory online that, you're scrolling through. The scroll bar goes on forever. You pick a provider that looks close to you geographically. You call that provider and you find out, oh, that's a Cracker Barrel. Or, oh gosh, that's that provider might be available, but it's 6+ months to actually see that provider. Or, in another case, you might actually get an appointment and you're not getting the highest quality of care at the lowest cost that you could get based off of the available supply of providers.
Right. So that speaks to me, which is you can literally be too broad. The burden of having everybody in network just has these, buried costs.
Yep. But the perception, Steve, I think from a consumer perspective or how the insurance company is traditionally sold, access is king.
Right. If everyone's in, it's going to be great. It's going to be better. But like
that's exactly
practical experiences may not be. It may just be a lot of TV shows you don't want to watch.
Yeah, I think that's a great example. You go out to your favorite streaming service name, Netflix or Disney Plus, or my kids are young enough that we're constantly on Disney Plus, and you go to pick a show and it takes you 45 minutes to curate a list of available shows because the volume is incredible. Where you go and pick a show and it's in standard definition instead of
right. Like it felt good on the way in. The brochure looked good, but the experience isn't quite there. Do you have this is sort of the do you have in your mind sort of measures of breadth? Like we've been looking at this problem. There are a bunch of network you look at, and like the number of orthopedists relative to the membership looks way out of whack. Or the number of nephrologists or PCPs and mental health, like there are networks that have 50 to 1, other networks that have 1 to 50. Yeah. Like, do you have sort of heuristics or kind of targets that you're sort of organizing around of what is good breadth look like?
Yeah, it's a great question. I think it's very specific to the service line or type of service, and a little bit dependent around what the competition is doing locally as well. We typically look at two different views: the one total population within a geographic area, and then the available supply of physicians by type. So be it orthopod, be it GI doctor, be it ENT. What's the available supply? And when I say supply, true supply. Like we've already done the hard work to kind of carve it out what's real and what's not real from that list of doctors. And then we kind of do a calculation around, okay, here's the total population. Highmark's population is Y% of that. If we assume in total all these people are going to these different providers, how can we get a Highmark network that's going to meet the needs of our people in terms of time, access, and then, as importantly, quality of care, of outcomes, experience, and total cost of care? So it's hard to say it's X, 50 orthopods per 1,000 members, but it's kind of like that type of measure, Steve, at its core.
And so, and you would look again, because you would be nervous if your ratio looked meaningfully different than the competition.
Yep. Unless for some reason we were trying to get into a different space. I think knowledge around that, Steve, is actually as important as difference. If we don't know where we stand relative to our competition, that's what makes me more nervous. If I know I have less providers than my competition, then I better be sure that the less provider is more accurate, providing more outcome, providing more quality, so we can tell that story relative to that.
So ignorance is sort of makes us nervous. I'm okay. I want to understand. So the access, I want to understand the relative access. If I'm narrower, I want to know that the subset I picked are better, more available, like some dimension, so that we can communicate to our members that hey, look, this network is exceptional.
Yeah, and at its core, at the end, when a person goes to use our product, that their experience and their outcome is better for having either a curated list of providers that are high performing versus if they were with a competitor, they're kind of swimming in the soup a little bit.
Right. So let's come. So the where we start from kind of conversation is interesting, but I know you guys are on a journey, and you sort of the second half of your introductory conversation, like, talk to us a little bit about that journey that you guys are sort of embarking upon.
Yeah, and I would describe that journey as almost like a transatlantic rocky, like is a very winding, meandering journey.
I thought you were going to describe it as jumping off a bridge, like bungee jumping or something.
Well, that might be a better way to describe it. Although we don't want to end up back where we started, is the describe it. The way we've been thinking about it, Steve, and in order to sort of provide confidence to our decision makers, is we need to understand what we describe, like, and you and I have talked about the art of the possible.
Right.
What is a highly optimized network look like for our members, with all guardrails removed? In a utopian world that does not exist, but if we were able to handpick providers, regardless of their affiliation, regardless of who they're contracted with from a provider perspective, if we were able to construct the highest performing network based off of whatever variable we were looking to optimize around, what would that look like? We have to do kind of that exercise first, so folks can understand kind of that guardrail of performance improvement. And I think, generally speaking, every time we've done that exercise, when I've seen it done in other organizations, the improvement that's available is stark and it's eye-opening. And that's really necessary for organizations that, I'll use Highmark and not-for-profit Blues, that has had a network that's been in place for a long time that hasn't had a lot of active management. It's hard to begin to think about managing your network, and the force of inertia is so strong to just continue the process that's been in place. You really need to have an understanding of what's possible to motivate people to begin the journey that we described, kind of the back and forth or the bungee jump off the bridge. I think one of the critical first steps is, hey, there's actual real improvement possible if we started to manage the network.
It's a really, I wrote a little note here. I do take notes along the way. Your point is interesting, which is, if I go back, it's like, I within Highmark, you have sort of a need to demonstrate that the juice is worth the squeeze. That, like, let me show you how big the gap is.
Yep, exactly. And that gap could be measured on outcome. It could be measured on access. We also have to measure, if we were to do the art of the possible, what's the gap that we might be creating relative to our competitors on an access or perceived access basis? Because that'll be the first question that our sales team or folks who are out in the market will ask us is, well, we've traditionally been selling on the fact that we're a Blues plan. We have every provider that has ever treated a patient in Pennsylvania. They're in our network, regardless of, if they moved out of the state 6 years ago, we've still got them in our network. So that, that perspective of selling on access versus selling on the quality of the experience and the outcome, you have to be able to tell the story as to what you're doing to access so that they kind of understand the give and take that we're asking them to do.
And so this idea of saying, look, friends and colleagues and teammates, this is how good a network could be. And if you had this network, it's not worse than competitor A and competitor B and competitor C in terms of access and sort of, brand, cachet. So then everyone says, wow, how do, that's interesting. And underneath that is, I think, a so what for me, which is, this is about courage, right? It may not be the bungee jump. I've actually got a different visual in my mind, Jim. You'll get this. It's the Indiana Jones, and when he has to take that leap of faith to the gourds to get to the chalice or whatever.
Yeah, like exactly.
it's that leap of faith that doing this has value.
That's exactly right. And I do think that leap of faith does not come lightly.
Right.
And there is an immense amount of internal work to do to inspire the organization to move in that direction. You and I have chatted in the past, Steve. We're entering an environment in healthcare where the traditional utilization management levers and prior auth that health plans have done to manage costs for a long, long time are increasingly becoming tough pills to swallow, both for the patient, for the member, for the provider, for the entire ecosystem. Creates an immense amount of work from an administrative perspective on both sides. It creates delays in payments to providers. It creates consternation from the members and the patients involved. What if there was a world where instead of having to do that, you have a high-performing network of high-quality doctors that the insurance company has already vetted are doing the right things from a quality and outcomes perspective, where you don't need the process to confirm that what they're prescribing or the treatment protocols that they're deploying for their patients are clinically appropriate or are not fraudulent or wasteful. If as an industry we can begin to move to that kind of approach, it becomes kinder, gentler, it becomes more collaborative between payer and partner and provider, and it becomes much more useful from the end consumer perspective.
Right. And do you see that as sort of a narrowed network or a network within a network?
I think it's both, to be honest. I think it's actually better if you eliminate the chaff to a certain extent. And so it may be like a variant in between. I think what we're finding is there's a lot of kind of low-hanging fruit, so to speak, that has accumulated over time that can be addressed and adjusted. I think from a member experience perspective, it's really hard to cut out hospitals, to be honest, from a network, because you need hospitals for emergency care.
You need the boxes. Boxes have to be there.
But specialists are they're the fundamental driver of care and quality issues. And so managing kind of the referrals between specialists, referrals from PCPs, we're starting to think of networks of having the appropriate amount of PCPs, having the appropriate, to your conversation earlier, Steve, the appropriate number of specialists by specialty type that are high quality and high performing. And then once you have those specialists, they naturally have alignment to certain hospitals. Those hospitals will have more of your volume, but there will be other hospitals that are there to cover emergency care.
Right. So this problem effectively, as I'm hearing you articulate it, gets worked from both ends, right? So the reality is, there in most markets, there's 3 health systems or 2 health systems, whatever it is, and so you either pick one, take both. Like those are a few boxes. Yeah. The other end, though, is there's a set of specialists, and the specialists who drive a fair amount of the cost and ultimately the value, because they're the members who are having more significant events. Those are the ones who are making that experience.
That's exactly right. And I think from the primary care perspective, for the everyday kind of things, that's where you can manage the network based off of the doctors who are engaging with their patients, who patients call first before they go seek a specialist visit. There are really well-defined metrics around PCP. Specialist is a little bit more ambiguous. I think where more of the effort is sort of underway to sort of get the right numbers and the right performers, to be honest.
Are there certain specialty, procedure codes, categories that you're more focused on? Like, so is it orthopedics and cardiology and, mental health?
I think it, like, I always say there's the big 4, cardiology, oncology, which is very tricky and difficult, neurology, and orthopedics. And you kind of can add women and children as the 5th, depending on the population being covered. Maybe not as applicable to a Medicare population, but incredibly profound for Medicaid or commercial. But those are the major specialties when we're thinking about variability, numbers of providers that we're trying to figure out the right way to construct a network.
Right. And you and I have had this conversation in the past, which is what you then start thinking about is in some of these specialties, the outcome or the cost structure can be have variability. So when there's variable output, variable experience, I want basically to have the higher value portion of that.
Exactly.
And the ones who aren't necessarily so positive, I want to sort of figure out if I can avoid them.
Yep. And that gets back to a little bit of the earlier conversation, Steve. The highest performing and those folks who are clinically following sort of guidelines, and doctors are all trying to do the right thing. Doctors are very busy. It's hard when you're seeing as many patients as most doctors are seeing these days. But there are some folks who outperform other doctors, and to the extent we can have a network that is all those top performers, then you can begin to really do unique and new things from an engagement perspective.
And then you're not worried about trying to manage the referral pattern. You're not the prior auth problem gets significantly lessened. The kind of persistency and the follow up, like all of the things that are symptoms, sort of go away because the operational routines are better.
Yeah, we like to think of it as a virtuous cycle, Steve. That
I like that.
If we have high performing providers that we can get our members into and get them aligned to those members, we typically will then see strong outcomes and lower total cost of care, which then feed experience. Our members will start to talk about the fact that this is a differential experience. And then that leads back up to the top of the circle in terms of more members,
better word of mouth, everything.
And then
goes
sort
positive.
of it all sort of feeds on that virtuous cycle.
So the leads me to this sort of question about how are you doing in getting your view of the providers? Like, are you, what's been the learning recently? What's the state of the union there?
Well, I would say in the last 15 minutes, we've had a very theoretical conversation, Steve. And we touched on it right at the beginning of this is a very complicated space to work in. Yeah. And I would say the insight and information at a provider and health system level is critically important for us to do everything we just described, right?
Yeah.
It's fundamental. It's table stakes. You have to have kind of what we just described. And it has to be validated to a level where you can communicate it internally to your stakeholders and begin to then tell the story to external stakeholders. When, an organization as big as a Blue Cross plan, when you go and begin to potentially remove providers from networks, that's not a step that's taken lightly. Providers will call immediately and say, what do I have to do to be in the network? Or what did I do to make you make the decision to not be in the network? So there are literally probably hundreds of evaluation systems out there to look at provider A versus provider B versus provider C. Our perspective is more is better. Knowing as much as you can about that provider is important. Having as many frameworks are important, and kind of having the ability to see a consistent story develop over 2 or 3 methodologies gives you a greater degree of confidence to actually tell that story externally. It's okay to tell it internally. And, I'm an actuary by background, but I don't want to be an actuary when I grow up. The actuaries can tell us exactly why a ranking is as it is. But until we have the confidence through multiple different ways to approach it, it's scary to tell the story externally.
So if I thought about, and again, I thought about someone staring at a screen, looking at all these oncologists or cardiologists or pick, like at the end of each row, the doctors are a row. At the end of the row, you're effectively saying, look, how did the Kelley Blue Book rate them? How did Cars.com rate them? Yeah. How did what is the U.S. safety transportation rating? And hopefully all of the one doc has 3 A's are like, okay,
that's exactly right.
I'm not in a methodology conversation. There's sort of an alignment here.
There's a consensus. Consensus makes the conversation a lot easier. And I think having access to that kind of information is really, really important as you're going down this journey in the the Indiana Jones or the bungee jump becomes it becomes easier. Like it's easier to do if there's validated and trustworthy information around the decision making.
And again, I think like all things you and I have talked about, there's probably an 80-20 here, which is what I mean by that is like on the list of sort of, if we think about providers and sort of a rationalization list, there's probably 50 to 80 of the 100 that people are like, yeah, that's not hard to debate.
Yep.
And so let's not hold back progress on the 50 or 80 for concern about the last 20. If we got to 50 or 80,
exactly.
the last 20 who are arguable, we can have lots of conversations later, but we can make huge headway if we took the obvious.
You said it very well. I view this process as very incremental in nature. The jump off or the moving the statue so the big ball comes rolling behind you, like that act is really, really important to do. And if you can convince the organization of the value of doing that on kind of the first 50% or the first 75%, it's worth doing that to get the momentum building. And then you could spend the next few iterations, the next year or the year after that to do the remaining 70 or 25% or 40% or 50%, whatever it might be.
Right. So it's funny. And again, now to talk about from the Quest side, we've been thinking about these provider records and about just adding more, so in some ways, overlapping content.
Yep.
Here's a quality score. Here's a performance score. Here's an appropriateness score. Like to provide yes, these are in theory, there's all similar things, but if this person is a tier 1 on all of them, or tier 1 on 2 of them and a tier 2 on the third, they're probably pretty good. I wouldn't worry about that one.
I think that's the exact right concept, Steve. Go back to what I said. More is better. And the more that you can have from a same story perspective, the more confidence it provides to take action and move forward, and the easier the conversation becomes.
It circles back for me thematically, and we'll probably need to be wrapping up in just a few moments. It does circle back to me to where you started, which is I need to show people the art of the possible, and I need to give them a sense that there's a lot of value on the table. The organizational issues and the sort of, I'm not saying inertia, but I guess hope that you could solve this place other ways. This one's probably not the one I want to like showing them that you can both that the value of the table is significant. Part one. Part two, that you can make first steps, to your point earlier. I can make first steps that aren't so sort of huge and so scary, and make progress that maybe the second step, which is maybe a little scarier or a little more complex, there's more organizational support.
Exactly. I think that value chain has to be multimodal. The only way you'll kind of get over the hump of inertia or fear and inspire and get the courage to move forward, it can't just be a story of, this would save 10% on cost. That's nice, but that's sometimes not enough to get folks inspired or encouraged. It has to be about quality of care, alignment. It has to be about experience, what the members and patients are seeing and feeling. And then that all leads to that cycle we described earlier of continual membership growth and competitive differentiation.
And I'm going to overstay my welcome here. Who are you telling the story to?
Quite honestly, Steve, it's virtually the entire organization. And that, to a certain extent, I'll boil that down. Because we're moving to kind of like a product-driven organization, really the story needs to start with the front line. You need to inspire the sales team to think about how they're going to position this with the external market. If you can't get there, if you can't inspire them, there's no way they're going to be able to inspire and sell this externally. So we typically work a little bit backwards. We start there, and then there are probably maybe oversimplifying this, 8 different internal groups of operators and logistics that have to be figured out. And then, becomes a investment conversation, right? Where does this stack up relative to 2 or 3 different things that might be on the table for us to do in then, next 2 to 3, 4 months?
What I'm intrigued by what you just said is you actually go to the end of the cycle, which is the salespeople or the market presidents or wherever it is. You don't go to your contiguous departments, not going to care management and quality.
That's right.
In some sense, you're trying to say, look, if we could do this, will everyone like it? And then
it's really is there a there?
Right.
And is there a there enough that the market will find compelling? And quite honestly, Steve, we'll often then go external before we do a lot of work with our sales team to say, bring in a couple producers, have a a couple sessions with members or consumers to say, if you had this experience and this was available, what is that worth to you, and how would that fundamentally change the way that you think about health insurance?
Right, you're using the business driver. You're not actually making this is not a. It's very smart. You're making this a question of the business objective, which is to grow the business and deliver member experience. Not let me talk about the way we make sausage. And
exactly. Well, if we can figure out that there's a there, then we've got enough smart people to figure out how to grind the sausage.
Right. So, hey, Jim, as always, I'm always fascinated, sort of learning from the way you guys are doing this in practice, and the good and the bad. Next time you come back, maybe we talk about what's working and what's not working.
I'd love to share kind of lessons learned as we get a little bit further into our journey. And I think it's as important to celebrate the successes as to talk a little bit about the things that didn't work. Because we're hopefully a little bit better than baseball. We're hoping for like a 50% hit rate, which in baseball is on
500.
Yeah.
If you can bat 406, man, you can be world record.
That's a Hall of Fame legendary stat.
But as always, Jim, great talking to you. Thank you so much,
Steve.
for joining us.
I really appreciate you having me.
All right. Back to you, April.
Thank you, Steve. And thank you, Jim, for joining us. And thank you, all of you, our listeners. We know you have other commitments and other things you could be doing with your time, so we're thankful that you chose to spend it with us. Remember, your feedback is invaluable. Please respond to the survey, send us comments, or send us topic ideas at social media at questanalytics.com. We want to hear from you. We produce this show for you. The Totally Adequate podcast is produced by Fowler House Films and Quest Analytics. Thank you very much.